Okay.
It's just bloody said it. When I first turned it on, it said we're recording. Okay. That's what happened last week, wasn't it? After I said it's recording, the bit that wasn't recording was that bit. Did you get, by the way, you got that follow-up, didn't you? I did a webinar on it. I sent you out earlier, which is basically the same as what we talked about.
Got it.
All right. So the other thing is with referred pain, generally speaking, well, you think about it, the further, does more referred pain suggest it's going to be a more difficult problem to treat? More intense or bigger spread? Does that suggest it's going to be more difficult or not?
I don't think so, because people's pain is so subjective that they might have a large intensity of pain, but it's actually not. Like once you reassure them and calm everything down, it usually sometimes for some people it gets better quickly.
Well, certainly the intensity is subjective. It's arguable though that the travel isn't. Now, obviously, in fact, everything is subjective. Let me think. You do a straight leg raise and you get a positive straight leg raise. You've got so many degrees of straight leg raising and it's limited. Is that an objective test or a subjective test?
Both.
Yeah. So your main, what's your objective criteria then? The range of motion?
Yeah, they're degrees.
Okay, so how do you know the patient isn't stopping that because they're anxious?
By a little bit of feel, how much resistance you feel like they're putting on you.
Well, maybe, but they're not really putting, they're just stopping you from taking out. It's not like they're pushing down against you, they're just resisting it coming up. This is my point though, pretty much everything you do, every test you do, apart from physical measurements with a goniometer, and even they're iffy, but everything you do has a subjective bias to it. You cannot really talk about because the argument then is the patient's telling me this is an 8 and I know it's not. Yeah, the patient's interpretation of that pain is accurate. Whatever they're saying that pain is, it's accurate. Even if you think they're a complete and utter wimp, that's their pain. Yeah. So, but the spread of it, not so much. If you ask somebody how far the pain spread and they say, and they draw it on a chart and they draw it down, is that subjective? Well, yeah, but how subjective is it? And at what point do you stop believing patients because everything they're saying is subjective? There's a lot of it about anxiety, but no, I don't think it's a spread as much because this isn't something they necessarily equate with severity. In fact, if you take a really acute patient and say, okay, it's hurting your back, is it anywhere else? No. Do you feel it in the leg? No. Do you feel it in the foot? No. This is what they do all the time, isn't it? No, I don't feel it anywhere else. It's just there. Listen to me. Read my lips. It's there. It's nowhere else. Are you sure it's not in your leg? Leave me alone. That's pretty much how these conversations go. Yeah. So I don't think the spread is as subjective as the intensity is. I don't think the limitation of activity is as subjective as intensity is. In fact, you use the limitation of activity to judge how intense it actually is, don't you? Now, this isn't true with chronic pain syndrome patients, but it is true with non-chronic pain syndrome patients because they're not tied up in their pain. So I think we can do that. So if we say that the pain is going all the way down the leg into the foot, it's not neurological pain, but it's going all the way down the leg from the back into the foot. Do you find that's more or less difficult to treat? Or not?
No, I don't think so. No, no. In my own opinion, I would say no.
Okay, let me ask you this then. What would you rather see in a back patient? They had local pain or pain going all the way down the leg?
Local pain.
Why? If it doesn't make any difference, why is that?
Yeah, because
they're more difficult to treat.
yes, yes, that's correct. Yes.
Yeah. Like, it's not a bad idea to turn these questions around a little bit every now and then. I think they are, and you can understand why now. With those factors playing into this, the intensity can go down, but if they've had it long enough,
It's a
then that
good,
pain
yeah.
can linger. So you may actually make them more functional and everything else, but they're still feeling it in the leg. And now you're looking at treating the pain rather than the pathology under those circumstances, because you already treat the pathology, but they're still feeling the pain. So this is when you might want to go into pain science and TENS and all the other shit that you've got. Yeah. Neuropathic pain is definitely a bad thing, though. This indicates nerve damage. All right, so the prognosis on that is much, much worse than if you didn't have that. By the way, try IFC if you ever have this. It often works. Try 100, big frequency of 100 cycles. But if that's not working, try 4. It's actually 3.9, but try 4 cycles a second. The problem with that is it can aggravate them initially. So if you can get away with 100, you don't risk that exacerbation. But if it's not working, shift over to 4, and it can work really well. And you just run the electrodes right way down the leg, or as far as the pain is. And it can actually work quite nicely. So often it doesn't, but when it does work, it works really quite well. Even when you try and take care of the pathology. Okay, now I wanted to talk to you a little bit about clinical practice guidelines. Did they teach you anything about this in school? Did they talk about this?
They talked about what they are, but not really great samples or anything like that.
Okay, did they say it was a good thing or a bad thing? Or were they non-committal?
I feel like
Bloody useless, aren't they, schools? I mean, seriously, they are completely useless. They won't give an opinion about anything. I'm going to show you a clinical practice guideline. Yeah, where the hell is it? Oh, I need you on share screen, don't I? Sorry. Where's it gone? Where's it gone? Where's it gone? I've got it here somewhere. There we go. All right. I really should clean some of these off. There we go. All right, this is the American Physical Therapy Association. There we go. So this is a clinical practice guideline for carpal tunnel syndrome. So you get all this stuff, all right? Summary of recommendations. Yeah, I've got some questions in there. It's saying that they can't recommend upper limb tension testing for carpal tunnel. Have any of you used this for carpal tunnel syndrome? To test it? You have, Nicole? See you nodding. How did you do with it?
Well, I feel like I've just run through like median ulnar nerve just to kind of sometimes rule things out if I don't have a definitive diagnosis, just to see if it's tension along the nerve that's causing some of the pain even higher up.
Did it?
Mainly as a test, and if there was something positive, then I'd do some sliders with it. There was maybe one patient where I felt like they had some symptoms with the testing.
Okay, so out of how many do you think?
I haven't seen too many carpal tunnels recently, so I'm going to say like 1 out of 3 that I've seen more recently.
Okay, so it's about a third then. Anybody else? Okay, the thing is, the reason I'm asking that is that there is conflicting, this is what troubles me about this stuff. There is conflicting evidence on the diagnostic accuracy and clinical utility of upper limb tension tests, such scratch collapse tests and tests of vibration sense and diagnosis, and therefore no recommendation can be made. So somebody said, yes, it works. Somebody said, no, it doesn't work. So you've got a conflict going on here. And instead of saying, okay, look, the balance is that you should do them or shouldn't do them, they say they can't make a recommendation. There is no leadership here at all, none at all. This stuff drives me up the wall. But this goes on. This goes on, and it goes on, and it goes on, and it goes on, and it goes on, and on, and on, and on. And on, not done yet, that's just not had a chance to do anything, and on, and on, and on, and on. So my question is, oh, what have we got here? Oh, look, medical screening, there we go. So now we come to the examination. After all that, we're now on page, I don't know what page we're on, to be honest with you. Can you all see it or not? You can't, can you? Can you? Yeah, okay. So I don't know what this actually tells you. Medical history, risk factor assessment, medical or diagnostic testing, including medical electrodiagnostics, social and work history. Now, in all that lot, how much of that is telling you what the diagnosis is? Let's say all of those are negative, all right? They got their work history doesn't suggest they should have it. Electrodiagnostic testing is negative. They've got no risk factors. They're not rheumatoid or rheumatoid family. They've got no medical history of this at all. And yet they're coming in with paresthesia here. Now, what does all that do? Now think about it, this is actually not rhetorical. You've got a patient coming in with paresthesia through there. All of that is negative. Now, what does that do to your mindset about this being carpal tunnel syndrome?
I feel like
If
it
you're
makes
just looking at that, would it not give you like a bias of ruling it out?
Yeah. Yeah. Does it rule it out? In fact, I'll go even further. So what else do we do here? This is all symptoms, all right? Now, it says rapid or gradual. I've got this going on, this stuff going on, and it came on suddenly, all right? I felt it, I woke up one morning, it was there, or it came on gradually over a period of a week or two, it got worse and worse and worse. Does that do anything for the diagnosis? No. What else we got going on here? Night symptoms. So all of this, if all of this is, what they're listing is all the things that should be positive or could be positive. But if none of them are positive and the patient has that, what are you left with for a diagnosis? Look at what you've got down the bottom. After all of that, right at the bottom here, activities that increase and decrease symptoms, the chief complaint, which should have been the number one thing you asked about. What impairments do you have? The rest of this, not so much prior treatments. That's all about treatment. So does anybody know what CTQ-SSSB stands for on CTQ-FS or DASH questionnaires are? No. So the main questions you want to ask are right at the bottom of that list. There's no prioritizing in there at all. By the time you get down to those questions, if you ask these in order, then you're already biased against it being carpal tunnel syndrome. And it's tough to overcome a bias once it's present. Very difficult. Medical screening, fair enough. You want to get out of the way. I don't know how much of this do you do. Do you do routine blood pressures, respiratory rates on patients? No, I never did neither. If you've got a carpal tunnel syndrome, when do you look at the neck? Or do you look at the neck?
I usually look at it right away in the assessment just to rule things out or to make sure it's not.
All right, let's do this. Let's do this. Okay. First objective tests you do with somebody complaining of this, what are they? I'll take you in order. Michelle, what's your first test?
Compression or a Phelan's test or the TAP test.
Okay. Tinel's? Phelan's, Tinel's, compression, release. Don't forget the release part of that. Anything else local?
Grip strength.
Test.
Okay, that's Michelle. Now, Nicole, your first test.
I would do the same as, like, locally, I would do the same as Michelle Tinel's.
But what is that your first series of tests? Local, or do you look at the neck first?
Well, I guess, yeah, you're right. I would probably look at like globally range of motion, all that stuff of the wrist up, elbow through shoulder to neck. And then I travel from the neck back down and almost finish
So you'd
off.
screen the upper quadrant.
Yeah.
Okay. Bola.
Yeah, for me as well, I usually screen upper quadrant. I do all the upper quadrant testing first because I want to be sure it's actually from there and not coming from somewhere else. And then
Right.
I'll make it more local. I'll do observe. I usually like to take a look, check for any thinner muscles, atrophy, and then do my test, Phelan test, tunnel sign, and the compression of the
Okay.
nerve and stuff like that. Yes, but I
All
always
right.
travel from up down to the
Okay.
fingers.
Tolu.
I'll do the same thing, like screen the neck and then come down to the specific test for carpal tunnel syndrome.
Okay. So why are you screening the neck? Why are you screening the upper quadrant before you make a diagnosis? Or
I would-
rather, let me ask the question differently. For what purpose are you screening the upper quadrant?
I feel like as a differential diagnosis to rule out differential diagnoses.
You can't do that. Which differentials?
Well, if it's something coming directly from like the neck, if I'm thinking like cervical radiculopathy or that sort of thing, that's I guess when I'm just getting a feel if it makes sense, if there's other things that are showing up that could lead me to thinking more into that process.
Okay, let me ask you this then. Do you do the same thing in the foot? If I have a plantar fascia, do you do a quadrant scan first?
Probably not, because I believe that's a little bit more specific.
Well, no, it isn't. This is the most specific thing, isn't it? Paresthesia air. What in the neck can cause that? Especially if they're not complaining of cervical symptoms. This is not a dermatome, is it? This is not segmental. This is a peripheral neuropathy. You wouldn't do it in the foot, but you will do it in the hand. Let's even in the foot. Let's take away plantar heel pain. Let's say they've got paresthesia. over the dorsum of the foot. Nothing else, just paresthesia over the dorsum of the foot. Would you look at the lumbar spine?
Yes, I would.
Probably.
Why? They got no symptoms in the spine. They got no pain or paresthesia running down the leg. They got isolated paresthesia. The problem is that you are not used to dealing with peripheral neuropathies. So you take the familiar bias, it's coming from the spine. That's exactly what you're doing. But there's absolutely no reason to believe that paresthesia in this area can be coming from the spine. Now, the spine might be playing a role. There may be an etiology in the spine or a partial etiology. It may be contributing to the problem, but you have to make the diagnosis first before you can look to see what's causing the diagnosis. This actually makes no, and to be honest with you, I've done this, I did this for years, I taught this for years. Always do a scan, then look locally. And it makes absolutely no sense, none at all. It really doesn't. And you break that rule every time you can. If this is heel pain, you don't look at the spine. But if I've got pain in here, I'm willing to bet you look in the spine, don't you? First. I think it's a misguided way of doing this. I think if you're going to look for it, it's about looking for etiology. It's not about looking for the diagnosis. If I haven't got neck pain and it's not running, do you look at the neck when you're doing the elbow, tennis elbow, or lateral elbow pain? Do you look at it first?
No.
So if you don't look at this first, why are you looking at this, the neck first with this? Make the diagnosis, then look elsewhere for etiologies. What else do I need to treat to deal with this? But you can't look for etiologies and contributors until you make the diagnosis. This is very much a local diagnosis. Plantar fasciosis is a local diagnosis, but it may well be contributed to by the spine. It may even have actually been kicked off by the spine. The spine may have caused the plantar fasciosis, but the diagnosis of plantar fasciosis is local. Make the local diagnosis first and then look for etiologies, because you can't do it any other way. If you don't know what the diagnosis is, how can you find an etiology for it? When you're making assumptions, you're assuming that this is carpal tunnel syndrome. You're assuming that this is plantar fasciosis. You're assuming that this is tennis elbow. So you're making assumptions and then working on that assumption, spreading out, looking to see what's causing it. And if you're wrong about that diagnosis, everything you've done in the spine and the periphery is wasted because the diagnosis was wrong. The assumption was incorrect. Plus the fact, usually you don't have to do it. Now, Nicole, you was talking about upper limb tension test with this carpal tunnel syndrome. If you've got a positive, and it's almost certainly going to have to be the median nerve to make any sense, isn't it? Has to be the median nerve test. So if you've got a positive on that, what does it do for your diagnosis of this being carpal tunnel syndrome? Does it change it?
No, not really.
No, it adds to it. Now you're thinking that there's another factor involved in this that you're now going to have to go look for, but it doesn't change the diagnosis. So unless this is referred symptoms, the neck has nothing to do with the diagnosis, except it may have caused it, but it's still not the diagnosis. And you have primary, secondary, tertiary diagnoses. Yeah. When you run into trouble, though, with referred pain is the referred pain itself can be coming from, say, the spine. So again, I've got medial knee pain that's coming from the spine, but no spinal pain and no history of spinal pain. And I've got this knee thing. So you look at the knee. The knee is negative. All of your testing done about all the questions you ask about whether it's a knee or not are all negative. So now you switch your hypothesis from this being a knee issue to being referred from somewhere. And you can take your pick now, can't you? Hip, back, SI joint, come to that. And then you can go and look where you want to. But now you're actually looking for the diagnosis. Because the referred pain is not the diagnosis. Then you've got the problem of the patient with back pain and knee pain. Now, you can make a couple of hypotheses here, rough hypotheses, that the knee pain is local to the knee, or the knee pain is referred from the back. And this is an atypical referral. So which one do you want to pick? Your choice. Pick one, for God's sake, people. Tolu, pick one. You're going to look at the back first or the knee first?
Can you take the question again, please?
I've got two pains. One's in the back, one's in the knee. Okay, this could be two local problems, one back problem, one knee problem, or it could all be coming from the back, because it never refers up from the knee, does it? You never get referring going proximal. So it's either a back problem that's referring to the knee, or these are two separate issues. So you pick one and you assess it. Which one do you want to pick, the back or the knee?
If the complaint is actually pain in the knee, I'm going to look at the knee first for sure.
Okay. Bala?
Yeah, but like I think you said the patient has pain in the knee and also pain in the back. Am I correct?
Yeah.
Then I will start with the back.
The back. Nicole?
I feel a little confused in the situation because I feel like I would need more subjective for me to make the total decision.
Okay, they walk, they get pain in the back on prolonged standing, but they get pain in the knee on prolonged standing. Yeah, I'm not making this easy for you, believe me. The knee doesn't swell up.
Okay.
They get pain in the knee if they sit too long. They get pain in the back if they sit too long. So there you go. What else do you want to know?
I mean, in that case, I don't think you can go wrong looking at either, because you probably have to look at both at some point. But I would probably start with the back pain as well.
Okay, well, let's say you are going to have to look at both if you can't differentiate them quickly. Michelle?
Yeah, I would look at the back.
Okay, so you can look at either one, can't you? Probably your best bet is to pick the easiest one to look at. And also, are you going to do a full examination of each? This is where your screening tests are useful. I can grab the knee and I can do quadrant testing on that. If they're not painful, these are fairly sensitive tests. If they're not painful, then the chances are there's nothing wrong with the bloody knee. In the back, it's a little bit more complicated. If sometimes the quadrant tests work, sometimes they don't work. I can do PAs up and down the spine, and the same thing. If the PAs are all negative, the chances are it's not the back. So you can use a screening test on either one and either include it in or exclude it. But now you come to the problem of hyperesthesias, because if there is sensitization, now segmental facilitation, for example, is going to produce hyperesthesia throughout that whole segment, then doing fairly forceful tests is likely to be painful as well. But mostly it's much more distinct than that. If the chance of you reproducing their pain that they feel during the day is unlikely. There are other issues here as well. Referred pain tends to be an ache. Local pain tends to be sharper. Now, they can both be sharp and they can both be achy, but the tendency is for referred pain to rarely become sharp and local pain to rarely become achy. So you can also follow along there as well. Tell me about the quality of the pain you have. Well, what you don't want to do is a complete exam on both. That's the one thing you don't want to do, because you're going to end up doing a complete exam on both, one of which may absolutely not be necessary. You've just wasted everybody's time. Yeah.
Hey, Jim. Just a quick one. So if would pain referral, would it make any difference? Like if the patient doesn't say anything, like she feels like the pain is being referred from her back down to her knee, would that make any difference in localizing the condition?
Well, it doesn't usually happen to start with. They might, particularly when these are discontinuous pains. So there's no topographical connection between the knee and the back. It's unlikely that the patient would associate the two. We have enough trouble doing that, let alone the patient. If it's continuous, then if it's a continuous pain from the back to the knee, you really don't have a problem. That's almost certainly referred pain, isn't it?
Yeah, definitely.
So it's not an issue then. So it's unlikely the patient's going to give you much information in that respect. I think that they're both coming from the same source. But this also works in the spine. I have a patient with pain on the right side of the back and into the upper buttock. Now, this could be purely lumbar. It could be purely SI. It could be both. So this is a much more difficult thing to sort out. You need screening tests again, but if you do PAs and you do a PA over L5, you're going to move the sacroiliac joint. Yep, so if they get painful, it's tough to tell. So what questions have you got that you could deal with this? Because testing is difficult.
Pain with transitional movements.
Happens with the back as well. We're not really looking at a sacroiliitis here. That's fairly standard. This is severe pain in the buttock. They have pain in turning in bed and all the rest of the thing. This just dominates anything else that's going to go on. So that's not our diagnostic problem. It's when we have a biomechanical dysfunction of the back and one of the lumbar spine. And is it one pain or two pains? Do they have an SI joint dysfunction, or is this just mimicking it and it's all referred from the back? You can pretty much say that the back pain is probably not sacroiliac originated, because again, you're looking at, if it's the SI joint, it's going to have to refer pain proximally, and that almost never happens. So it's very unlikely that the back pain is coming from the SI joint. Do you know Fortin's test? It's really a very interesting test, poorly researched, very poorly. The test that Fortin came up with is, you say to the patient, I want you to put one fingertip on where you believe the pain is either coming from or where it's at its worst. And a positive test is they put one finger, not two, one finger, medial and a little inferior to the PSIS. And that's extremely sensitive for SIJ. So if they put it anywhere else, the chances are this is not an SI problem. So in this case, you're looking for a negative test. But it's very, very sensitive. The problem is, when he did this, he didn't do a control group. So he did it right, except for that. So he basically injected the SI joint with local and short-term and long-acting anesthetics, and he got the results he was looking for. So it's very, very sensitive, just not very, well, we don't know how specific it is because he didn't have a control group. It's probably not bad. It may be as much as 60%, don't know, but very sensitive. So if it's a negative test, you can pretty much rule out the SI joint. So that's your question. Well, there's another test that I use, which is my test, but not mine, but a lot of people use this, but I've called it the objective Fortins. One subjective, which is the proper Fortins. The other one is to get your fingers in the SI sulcus and rub the bloody thing. and you're looking for abnormal tenderness on the side that's in trouble versus the other one. So I think if you get both of those things, a subjective and an objective findings, you're pretty close to saying this is the SI joint that's causing the pain. Now you can have an SI joint dysfunction that's asymptomatic, and the subjective finding will be negative. But the objective finding, in my experience, has always been positive, except in one case. Every time I've done this, manipulate the joint and everything improves. But the subjective findings, the proper findings, doesn't deal with asymptomatic SI joint dysfunction. Okay. Screening tests, it's all down to screening tests. You just got to be careful which ones you use. If you use quadrants, you're still stressing the SI. If you're doing PAs, you're stressing the SI. So you've got to be a bit careful about which screening test you're using. It's just a matter of thinking your way through it. Is that okay? If you really feel the urge to look up, you want to get involved more in pain sciences, particularly in this aspect, referred pain and so on, there's about half a dozen. Let's see if I can find them. What's that? There you go. So half a dozen theories, some of these dating back to about 1890. And looking at these now, pain science bores the tears off me. It really does. It just drives me crazy. But from what I've looked at these, they all seem to have something true about them. The chances are it's probably a combination of all this going on. But if you're really interested, start on Wikipedia, and then they've got the citations for these. Okay, I'm certainly not going to go through that drive. This just bores me, puts me to sleep, this stuff. But if you're at all interested in this, is what you should be looking at. I don't know if it helps you practice very much. So, where's everybody gone? That's not it. I've lost you all. Where are you all? Well, I've got you. I haven't got me. What's that? Okay. All right. So, come on, have I outraged anybody by this? I honestly am. I'm sorry, but I'm really disappointed in what's being taught in schools. Much the same when I went through. We had to go and visit a pain lab. Actually, it was a physiological laboratory, that pain and everything else. So the guy in there said, so what causes muscle pain? And we gave him the answer that we had got from school, and he went, do you know, that was debunked 50 years ago. They were still teaching the same crap that actually was disproven 50 years earlier. And 50 years earlier than that was about 1910, for God's sake. That wasn't 1920. I'll take a bit of credit, 1920. But they still do this. Why talk to you about clinical practice guidelines if they're not going to recommend you use them? I'll tell you why you shouldn't be using them. Now, it's come full circle now. So clinical practice guidelines do have a purpose. And there's some examples of them. The X-ray protocols, Canadian C-spine rules, Ottawa rules for the ankle and the knee, Nexus LRC. All of these rules are practice guidelines. And you're familiar with them, yeah? They're all practice guidelines. And what they're doing is, in this case, they're not telling you how to treat the patient. They're telling you whether or not to do an X-ray. And the numbers are so good, they work. So when you've got something like this where you're actually trying to cut down on expenses, they can be quite useful. There's another one called Gold's algorithm, which is about dealing with patients with chest pain. And it's about cutting costs. and cutting time so doctors don't spend as much time on these people when they don't need to. And it works really well. Can they get the doctors to do it? No, they won't bloody well do it. They're telling them to only ask 4 questions, basically, and to do a couple of tests, 2 tests, but they don't do it. They hate it. They absolutely hate it, but it works. If we're dealing with something severe, and it's the same thing for us as with that GOLDS and with the radiology CPGs. Let's say you're dealing with VBI, all right? You have a patient who's dizzy and they've got headaches and they've come in for a neck problem. Your question is, does this need imaging, appropriate imaging? And if you're going to send everybody back with those 3 symptoms, you're going to be sending an awful lot of people for fairly complex and expensive imaging when you don't need to. So if we can cut that back a bit and we say, I think this probably works, is headache, posterior headache and dizziness are the 2 most common symptoms of VBI. Both of them are extremely sensitive for VBI, by far. The rest of them may be specific, but they're rare. These 2 are the most common symptoms. So they've got both of these. So do a lot of people, especially when you start talking about defining dizziness. It's almost anything. But if we can then say that the headache and the dizziness are coupled together, that is, when I get the headache, I get the dizziness. When I get the dizziness, I get the headache. As one gets better, the other one gets better. As it gets worse, this gets worse, and so on. And we can say, okay, now both of those symptoms could be coming from the neck, and we can decouple them from the neck. That is, when the neck gets bad, the headache and dizziness does not necessarily get bad. Then we can couple the dizziness and the headache and decouple them from the neck pain. For me, that would be enough to refer it back to the emergency room, probably by ambulance and in a collar, and ask for proper imaging. Now, it may well turn out to be that's okay, but given the risk involved with this patient, that CPG, I think, is fairly useful. The risk to you doing range of motion testing on this patient or decline tests or whatever else you want to do, if there is a vertebral artery, that risk is a stroke or death. So given those conditions, you're probably better off using a CPG than detailed information from a prolonged exam. So they do have their uses, but as far as you using them for treatment, I don't think they have to have a lot of use. We come back to that CPG I showed you, and it goes on and it goes on and it goes on, and then it's fluffy. Unless the level of evidence is A or B, pretty much what they're saying is don't use it. And yet, that's the reason I asked a question about doing dynamic upper limb tension tests with carpal tunnel syndromes. It works sometimes. Now, how often does it work? I don't know. Maybe that's what they should be researching in the bloody universities instead of the shit that they seem to do. Because you come down to this, when was the last piece of research that you've ever seen done in a university by an academic that you could use in your practice? Can you think of any? I can't. I really can't. The good stuff comes out of Australia because they do a master's program there where they have to do research. And it's very clinically orientated. That looks to be some of the most useful stuff that comes out of there. But it's done by clinicians. The research that's useful is done by clinicians. And the academics seem to be twiddling their thumbs and looking for tenure. So when they come out with this stuff, these CPGs and everything else, it doesn't have a lot of clinical value. You're going to wade through 52 pages on carpal tunnel syndrome every time you see one, because you won't remember it. You still come back to the same stuff, the pathology, its stage, and the anatomy. And that's what you use all the time to determine treatment and diagnosis. All the time. That's what you've got. That's what you've got. That's the only thing you can do. Maybe next week we'll have a rant on evidence-based practice. Okay. Okay, do you have any questions for me?
Yeah, it just said pathology, anatomy, and something else.
And the structure. Well, it's pathology and anatomy. Pathology and anatomy. Yeah. That's what it is. This is your pathoanatomic diagnosis. That's exactly what you can use. And you've got to use logic with it. And you've got to know what the treatment's supposed to do. And then you can make your own mind up whether it actually does it or not. They're telling you not to use ultrasound with carpal tunnel syndrome. And the reason is, given the way it's carried out by most therapists, don't use ultrasound on anything. Does it work? I know they're teaching us in school, don't do it. Well, they were at the U of A. Did anybody get taught that? It's no use.
The research behind it that they were showing us was very poor. So
Yeah,
they
and
said,
I've got no argument with that at all. And it's because they keep doing low dose treatments. I mean, seriously, you're rubbing this bleeding thing up and down around the shoulder. You're doing this around the shoulder. Often it's on pulsed anyway, and you're rubbing it around that, and you've got a lesion that's about that big. How much treatment does that get? So what does that do to the research? Yeah. Well, maybe next week we'll have a rant on evidence-based practice, unless you can come up with another topic that you want me to talk about. Or you can just listen to me rant again. All right, guys, I'll get you the recording now. What did I miss from the recording? I know it's not about referred pain, but I can't remember where we came off it.
I think it was the difference between referred and radiating pain.
Okay. Actually, what I'll do is I've just done a video for the Americans. I'll send you a copy of the video.
Okay, thank you.
Okay. All right, great. I will see you next week. Have a good week. I am planning on getting drunk on somebody else's booze or something. I've got to listen to them rant on about Obama. They're still going on about him, Trump, and the new one, Biden. If I've got to listen to that, I've got to be drunk while I'm doing it. Talk to you next week, guys.
All right, thank you so much.
Thanks,
Enjoy your
Jim.
drive.
Take care, everybody.
Jim.
Bye.